Welcome all to the Neuroblastoma Parent Global Symposium 2020. My name is Josi, Demetriou, and I'm from Children's Cancer Institute. I will be moderating this session today. I'm also the parent of a child that was diagnosed with stage 4 neuroblastoma at only 8 months old. So I do know firsthand, just like you all, the importance of knowledge and education in this insidious disease. So I'm honoured to be here today. This session is entitled ANZCHOG, Treatment and Trial Updates, and is being presented by Dr. Toby Treher, who's a wonderful clinician at Sydney Children's Hospital in Australia. But before I hand over to Dr. Treher, I'd just like to draw your attention to the Q&A button, which is at the bottom of your screen. So that is where you submit questions for Dr. Treher, which will be answered at the end of his session. Now, if the button is not working, just hover over the top so that the cursor appears on top of it, and hopefully that will work. If you do see a question that you like, please do give it a thumbs up, and that will literally just bump it up to the top so that Dr. Treher knows that that is a crucial question to answer. Okay, over to you, Dr. Treher.
Lovely. Thank you very much, Josie. Now I'll just share my screen, and I hope that I won't muck it up this time. Now just let me maximize this. So look, it's a real pleasure to be able to again speak to you again. And this time we're sort of really focusing on treatment and trials. And so the other question is, what's ANZCHOG? And that's really the Australian and New Zealand Children's Haematology and Oncology Group. So I showed this before. This is sort of my disclosure. So I've actually been on the board of the ANZCHOG for 10 years. I came off this year. And really it's a local discipline group for professionals who work with children with cancer, but it's also a local trials group as well. Now, if you look at incidence and outcome for neuroblastoma in Australia, this is data which is published earlier this year, and this comes from the Australian Childhood Cancer Registry, and it's really looking at the incidence and outcome of neuroblastoma in Australia in the period from 1983 to 2015. So we've seen a very slow increase in the number of cases of neuroblastoma over that period of time, which just reflects the population growth. So we see somewhere between 40 to 60 cases of neuroblastoma a year. And if you look at the outcome over a period of time based on age or the year of diagnosis or metastatic status, you see sort of similar trends in Australia as you do across the world. So younger patients in here under 18 months do better than older patients. Patients who were diagnosed in earlier time periods, 1983 to 1993, had poorer survival compared to the contemporary era, 2004 to 2013. And again, generally children who've got non-metastatic disease, they have a better survival than those who've got metastatic disease. And particularly for those with metastatic disease, the younger patients do better than the older patients. Now, in terms of what sort of currently questions are being answered and asked in frontline international clinical trials for neuroblastoma. So I just put this table together to sort of highlight not all frontline clinical trials for neuroblastoma, but really to sort of look at some of the randomized questions that are being asked. So in terms of induction therapy, that's the initial therapy for the chemotherapy that's used in Europe and the CEPIN group. They're looking at two different chemotherapy programs, one developed by CEPIN, Rapid COGEC, versus a German variant. They're also looking at the question of single versus tandem transplant, a question that was done by the US, and they're trying to confirm that data. They're also looking at radiation therapy to the residual primary tumour. So this is a trial that's going to be available to children in Australia and New Zealand. The Children's Oncology Group in the US have done some trials at the moment in their frontline trials where they're looking at trying to improve outcome with induction therapy by adding either high-dose MIBG therapy for some patients, and then patients who've got an ALK mutation, they're also adding an ALK inhibitor. Unfortunately, that trial is not available in Australia and New Zealand. The other exciting thing that's happening in frontline therapy is to use the antibody treatment, unituxin or denaturumab, in induction therapy. Some data has already been published by the St Jude's group. The Children's Oncology Group have just done a pilot study, which was open in Australia and New Zealand, has just closed. Again, CEP and the European group are going to also run a trial looking at that as well. And again, in children with non-high-risk neuroblastoma, the main dominant theme in clinical research has been observation and reduction in therapy in many patients and using sort of biology and treatment response to guide therapy. And there have been trials for that done by both the CEP group and also the Children's Oncology group that are available in Australia and New Zealand. If you look at sort of current treatment standards in Australia and New Zealand, we have strong links with both Europe and North America. And so many of our centres, though, will use treatment programs that are either derived from the Children's Oncology group or from the European group CEPIN as well. And so generally, if you have a child who's diagnosed with low or intermediate risk neuroblastoma, they could potentially be enrolled in a trial either run by the Children's Oncology group or CEPIN or be treated with the standard of care. We've got a registry study for children with spinal canal involvement. Again, for high-risk disease, we don't actually have any currently open trials at the moment in Australia or New Zealand. And so most children will be treated either according to the currently best available Children's Oncology group or European CEPIN versions of high-risk therapy. The CAG pilot, as I said, for the dinutuximab with induction therapy is just closed in Australia. We haven't been able to open the MIBG or ALK study from Children's Oncology group. The next CEPIN high-risk study is about to open and is likely to be available to most centres in Australia and New Zealand, as is the CEPIN pilot for dinutuximab beta with induction therapy. In the relapse and refractory setting, again, the PRISM is the local personalised medicine trial, which is open to everybody in Australia, and we're hoping that a version of that will also be available in New Zealand. And again, one of the more commonly used relapse therapies is antibody therapy with irinotecan and temozolomide. And again, most children in Australia and New Zealand can access this therapy off study. And again, there are a number of early phase trials. Now, one of the things that can sometimes cause a little bit of concern and worry for parents is there actually are differences in the standards of care between North America and Europe CEPIN. And that's just a reflection of the way that the clinical trials have been done. Because they're different, it's not a problem, it just means that they're different. And so in Australia and New Zealand, we have access to both the Children's Oncology group type therapy and also CEPIN therapy as well. So the initial therapy that's used in America versus Europe is a little bit different. So the modified Sloan-Kettering induction chemotherapy in CAG versus the European version of rapid COGEC versus the GPOH. The timing of surgery for primary tumour is a little bit different, end of induction versus during induction. At the moment, the standard of care for Children's Oncology group for transplantation for high-risk neuroblastoma is 2 transplants, whereas the data in Europe supports a single transplant, although that's going to be a question on the next trial. Again, radiation therapy on a CAG standard would be the primary site plus metastatic disease that's still MIBG added after induction therapy, whereas in Europe, they tend to only irradiate the primary site. And again, there are slight differences in the way the anti-GD2 therapy is used in the US versus Europe. So then the antibody therapy is used with GM-CSF in North America versus Qarziba without GM-CSF in Europe. And so in Australia, there are patients who have high-risk disease where their centre might treat their children with a COG-based approach, and they might be offered a tandem transplant, whereas in our centre, we tend to follow the CEPIN approach. And again, for good responding patients, we would use a single transplant. Again, sometimes the other thing that can cause a little bit of concern is what's the best criteria to go ahead with transplantation for children with high-risk neuroblastoma. And again, in COG, you can go to transplant if you have either a stable disease or better, whereas the CEPIN approach is tended to emphasise having a better response before going to transplant. Now, the reason why there are differences is that's where the clinical research has been, and these standards are not necessarily going to stay the same, and things will change as new trial data becomes available. So ANZCHOG, what's that? So that's the local sort of Paediatric Oncology Society for all professionals who work with kids with cancer. But again, it's got a strong focus also on clinical trials. And so this is just really sort of a diagram sort of representing how the ANZCHOG organisation works. And so really what I wanted to focus on is the fact that actually they've realised that it's important to have active processes and organisations that support clinical trials to make sure that we open trials in a timely fashion and that they're available to children who need them. And so part of the ANZCHOG organisation is a clinical trial service. And so they have a number of staff whose sole role is really to help facilitate the opening of clinical trials and the running of clinical trials in Australia and New Zealand. And they have a number of staff members who are involved in terms of doing that. And so they're trials managers, quality managers, trials assistants, coordinators. ANZCHOG has also got disease groups. And so again, in terms of neuroblastoma, the solid tumour group is probably the most important disease group in regards to that. I talked before about the importance of international collaboration. And again, there's a strong collaborative network that ANZCHOG has in terms of clinical trials collaborations. And so we actually have trials that are open in collaboration with many trials groups. And so this is just a list of collaborators for the organisation as a whole. But also I've highlighted and bold the ones that are important, particularly for neuroblastoma. So for the Zero Childhood Cancer Project, which is really for the personalised medicine for relapse disease, Children's Oncology Group for frontline and relapse disease from North America, CEPN again, which is really for frontline and relapse trials in European groups. The ITCC is an early phase trials group for children with relapse disease from Europe. We also have associations with St Jude's Children's Research Hospital and also the University of Birmingham as well. So the next couple of slides really sort of illustrate sort of the relationships that actually we have for trials, because they actually change and they're a little bit different from different organisation. So the Children's Oncology Group is a very large trials group. It's got over 200 member institutions, predominantly in North America, but all the Australian and New Zealand children's cancer centres are members of the Children's Oncology Group. And so that it means that we can access Children's Oncology Group trials, and we tend to have a direct relationship between COG as an organisation, and they have a direct relationship with each of the individual hospitals. But there is an important relationship between COG and ANZCHOG. One of the problems that we've had over the last 10 to 15 years is that sometimes there are trials that are made available through COG in North America that we have trouble accessing in Australia. And so our executive officer from ANZCHOG, they have an ongoing dialogue and they meet regularly with their counterparts in the Children's Oncology Group. So when trials are being planned by the COG, we're hoping that they understand that we would like to open them where we can in Australia and to facilitate that process. In our relationships with Europe, it's a little bit different. And again, rather than having either CEPN or the ITCC actually have a direct relationship with individual hospitals, they like to have a direct relationship with ANZCHOG. And so the main intermediary in terms of bringing CEPN trials and ITCC trials to Australia and New Zealand is a direct relationship between ANZCHOG as an organisation, and they help facilitate to bring and open trials from CEPN and also the ITCC to Australia. And then those trials are distributed to the individual hospitals. There are also quite a lot of trials that actually come from different pharmaceutical companies. And again, that's again a different relationship that we have. And again, most of the relationships that we have with pharmaceutical companies are actually direct relationships with the hospitals, and all of the children's cancer centres have got their own clinical trial services. And so that a drug company that have a drug that they would like to test in a trial for children with neuroblastoma, they will approach individual centres, and then they will make decisions about where and which centres they might offer their trials to. So in this particular case, we might have one drug company, they might have their drug and they may offer it to a number, but not all of the Australian and New Zealand children cancer centres. And so in this situation, you might find that the access to that treatment is available through a clinical trial. But if you come from a centre where it's not open, you might have to travel to go to get access to that particular trial. And again, for another drug company, they might have a different relationship for their study drug. And so you might find with pharmaceutical company sponsored trials that there'll be a range of number of different trials open. They're not necessarily open at all centres, but across Australia and New Zealand, there are quite a large number of trials available to us through pharmaceutical companies. Now, ANZCHOG supports some trials directly, and so the precision medicine trial PRISM is important, and again, that's supported by ANZCHOG, multiple funding sources for that. Specifically in terms of neuroblastoma, there are a number of other sort of international trials that also ANZCHOG, their support's important in terms of getting these trials going and available in Australia. And so some of these associations are with the University of Heidelberg at the ITCC, so for the INFORM2. And again, that's for not just high-risk solid tumours, but also for children with brain tumours. We have a study open for children with relapsed solid tumours and leukemia with the University of Birmingham, and that's a study using an agent called recombinant pegylated arginase. We've got an investigator-initiated study called the North trial using panobinostat, again, which had been opened in Australia in conjunction with the sarcoma group. although that was originally going to be open for multiple different types of cancers, including neuroblastoma and osteosarcoma, unfortunately at the moment that's not available for children with neuroblastoma. In terms of the CEPN group of trials, again, the collaboration between CEPN and Australia is through their ANZCHOG, and they've got a number of studies, the high-risk trials, the low and intermediate risk trials, and the spinal canal registry study open as well, again, in conjunction with ANZCHOG. And again, this is just a small selection of some of the pharma company sponsored trials that are available through our centre at Randwick, but again, there are many others. And so each individual centre in Australia will have a number of pharmaceutical company sponsored trials. In this context, also the Children's Oncology Group, we've got a relapse trial that's available across Australia and New Zealand, and that's a combination of using irinotecan and temozolomide dinutuximab, the antibody, with randomised DFMO. And then again, there are a number of other sort of targeted therapies, so ALK inhibitors. Again, we've got a multi-tyrosine kinase inhibitor trial. And again, there's also a study for venetoclax, and there are also many others available in Australia and New Zealand as well. Now, I wanted to sort of move over to a more sort of slightly philosophical discussion about there are differences between clinical trials and clinical practice. And so before, when I was talking about the integrated and collaborative network of research, trials are a very important tool for us to be able to take a therapy which we think is likely to be helpful in neuroblastoma and to do the work to show that there's evidence that it's safe, it's tolerable, and it's got some level of activity. However, a clinical trial is not exactly the same as clinical practice, and there are significant and important differences. And so it's important to be aware of that as a family who has a child affected by neuroblastoma. Again, trials are internationally regulated, and so in Australia, the important sort of standards for regulation of trials are through the National Statement on the Ethical Conduct of Human Research, and there's also the Australian Code of Responsible Conduct of Research. And so safety is an important part of conduct of trials. And it's also important to be clear about what your goals as a family are, as opposed to what the goals of the trial are, because sometimes they don't always align neatly as you'd like. And so it's very important in terms of understanding what the goals of the trial are and how they align with your goals as a family. When we think about trials, they're broadly divided into what we call early phase trials, and then there are late phase trials. And really the role of early phase trials is to do the initial evaluation of promising new therapies and to take them into patients to find out, are they tolerable? Are they toxic? Can we find the right dose to use? And so really the primary goal of early phase trials is not about curing patients as their primary goal. It's about trying to find whether or not, A, can we use the drug? Does it have severe side effects that would stop us from using it? Is it tolerable? Can we find a dose? And so in the early phase trial section, again, there's been a lot of focus on trying to make sure that trials design is efficient, so you get an answer quickly and you can move on. And the other thing is also that often we know that many new drugs don't work very well as a single agent. And so there's often a focus also on the early introduction of trying a new agent with a combination therapy. And that's a design that also helps to maximize benefit for individual families. Now, unlike early phase trials, late phase trials, often phase 3, phase 4, they're actually about improving cure rates, improving therapy, doing things better. And so that's about refining, improving the standard of care. And so the early phase trials is all about finding out about new drugs, how to use them best, not primarily focused on improving cure rates, whereas late phase trials are taking agents we know a lot about and trying to integrate them into the standard of care. So if you looked at sort of the way trials processes work diagrammatically, that's sort of that's the classical description. So you have preclinical research that leads to the identification of an active therapy, the early phase trials, small numbers of patients going into larger phase 2 trials. And then when you can show that the drug has got a safe dose, it's got some degree of effectiveness, then you can then take it into large standard of care trials. And so again, it's important to sort of think about also what are some of the major and some of the minor or secondary goals of trials. And again, to emphasize that the major goals of early phase trials are about dose finding, about making sure we can get the measured drug levels in the patient to make sure we understand about toxicity and tolerability. So it helps us as clinicians learn how to use drugs effectively and safely. Again, secondary goals are also in this situation often measuring clinical activity and looking for biomarkers or tests that we can use to define patients either who respond well or who might not respond well. and also to get samples for biology. Often early phase trials use small numbers of patients. In the ideal design, they're efficient so that they'll get done in a short time frame. And again, generally the population of patients for early phase trials is relapse and refractory patients. And again, often these are single arm trials. They're often small, some are randomized, and again, there are some multi-arm trial designs as well. In contrast, a phase 3 trial is larger. Again, you're trying to introduce a new therapy that you know you've got a fair bit of data about, and trying to find out, can you add that to the standard of care or replace a part of the standard of care to make a chance of cure better? And again, in general terms, for many phase 3 trials, the population of patients you're looking at is newly diagnosed high-risk patients or newly diagnosed patients with neuroblastoma. They can be single-arm trials. Again, they're often randomized. One thing that also we don't necessarily understand so well is actually how families make decisions to go onto trials. And so the Behavioural Sciences Unit at our hospital, they've been doing some research in this area. And so Eden Robertson and Claire Wakefield, Joanna Fardell and Richard Conn, they've actually done a pilot study to try and actually understand actually how families make decisions, and also can we help them to make a decision. And so this is just to sort of highlight some research that they've done called Delta, which is really about trying to understand what are the important things for families about understanding trials, and what information is important to help them make a decision about should they participate in a trial. And again, I think this is an important area in terms of trials research, because again, I think it's important to understand as a family where your goals are for your child as opposed to the goals of a trial, and do they align well, and does it make sense to go onto a trial? Now, when we talk about early phase trials, again, the patient population is generally for patients who've got relapse refractory disease. And so it's important to also be aware what the underlying likely outcome is going to be. And unfortunately for children with high risk relapsed or refractory neuroblastoma, many children will not survive. And again, one of the difficulties can be when you're assessing a trial is that you might have a lot of information that you become aware of from multiple different sources. And, you know, people will say, well, I had this treatment and, you know, there's been a very good success rate. And that may very well be true. But again, it's also important to be aware that you've got to understand many patients with high-risk disease at the point of relapse or with refractory disease, it's a big struggle to actually get these patients cured, and cure rates and long-term survival rates are very, very low. So in terms of balancing up the risks and benefits of therapy, you sort of need to also be able to take into account what is the real chance of success, and be able to take one step back and think, okay, the people who are talking about this trial to me, they say it's going to be really good, but is it really? And so you need to also be able to go into decision making and thinking about trials with some degree of objectivity. And that can be very, very hard. And the other thing that's also difficult is sometimes there are lots of different trials that you might also be eligible for your child to participate in. And so how do you also help, or how do we help you make decisions about, is it better to try one treatment or another, or go on this trial or go on that trial? I won't spend time talking about that. Again, the other thing that's important to focus on in terms of trials, they're very important for us to generate information that's helpful to understand about how drugs are used, but clinical trial populations don't always actually reflect the whole population of children with, say, relapsed or refractory neuroblastoma. One of the really important things about trial design is you're aiming to answer a question efficiently, and there's a strong focus on participant safety. When you're trying a new therapy or a treatment, there may be unexpected toxicity. So you want to be able to do it in as safe a way as possible. And again, it also means that when you're designing a trial, that you actually want to have a very defined population of patients that go onto the trial. And so you might find that there are quite stringent inclusion and exclusion criteria. And sometimes also some trials groups are mainly focused on only looking at, say, disease at one time point. So for some of the recent, say, North American trials for relapse, they've been looking at the first point of relapse or first point of refractory disease, rather than children with multiple refractory disease. And one of the reasons why there are often stringent inclusion and exclusion criteria is that we want to find a patient population where we think it's likely to be safe to give the drug, and that the patients who are going to get that drug are unlikely to have severe toxicity from the therapy. And so from that point of view, sometimes children have got relapse disease, but unfortunately they've got other medical problems that are going on at the same time, which means that they may not be eligible to go on a trial at the time. So if you think about the clinical population, all children who say have relapse or refractory neuroblastoma, that population might be large. And there might be a smaller population who actually meet the eligibility of a trial. And again, even if you meet the eligibility of a trial, you might not be able to enroll in the trial for various other reasons, or you might choose not to. So again, when we're thinking about trials data and what they mean to the larger population, it's always important to remember that a trial population is very, very defined, and we've got to think about how that information then relates to larger populations as well. Again, one of the other critical issues is that there's been an absolutely huge explosion of knowledge and understanding about biology of relapsed high-risk neuroblastoma. So I showed this slide in the last talk, and really I'm just showing it to sort of emphasize that there are lots of potential treatment targets that can be looked at in the relapse and refractory setting. And again, there are lots of different trials that are out there and available for children to potentially go on to with relapsed or refractory neuroblastoma. And so how do you pick a trial or a treatment in the relapse setting? And again, that's really, really hard. And so again, this is where the concept of personalized medicine becomes or is increasingly important, because really what we would like to be able to do is understand more about the individual child who's got relapse disease. And if we think there's likely to be a therapy that's going to benefit them the most, that's something that we would like to know, so that's information we could share with you and help in terms of the decision making. And so that's really where the genesis of the whole idea of personalised medicine is. And so in the personalised medicine program in Australia, which the trial called PRISM run by the Zero program, again, the whole idea really behind that is for children with high-risk cancer, relapsed refractory high-risk neuroblastoma in this context, is really trying to generate information that would help clinicians help you make decisions about what treatments that might be worthwhile pursuing. And so from that perspective, it's about collecting samples from patients with high-risk or refractory relapsed neuroblastoma, analysing it in the laboratory, getting some genetic information, some genomic information, hopefully doing some drug modelling, and then actually taking all of that data back and going to what we call a molecular tumour board, where you can actually then go through the results and actually talk about, did we find genetic changes that suggest this particular cancer is going to be susceptible to a particular treatment? Were we able to find any in vitro drug screening results to suggest that this particular relapsed neuroblastoma is sensitive? And do we have any other ancillary data? And discuss that with the treating team, and then issue a report that then might hopefully be able to be used to help select therapy. So in the way the PRISM study has already been working in Australia, it's been done for a large number of children already. And again, this is what's called a swimmer's plot. And again, this is some data that's been published from the PRISM trial. And this is really just looking at, in this particular graph, this is over 30 patients who've got high-risk cancer. There are 3 children who've been on the PRISM trial with relapsed or refractory high-risk neuroblastoma. And in this context, they've gone through the PRISM process, a sample of the tumour has been taken, it's been analysed, it's led to a recommendation in therapy. And really what the swimmer plot is really just trying to show is that we were able to find a therapy, the children were able to access the therapy, and in this context, we're able to sort of see that for some of these patients, they were able to have their treatment and have a response for over 6 months. And so this is very, very, very early data, but what we would hope to be able to achieve is that by doing more personalised analysis of individual tumours, that we can actually help make better decisions about what therapies might be helpful for specific patients. Now, how do we improve clinical trials access? So we have some trials available through Australia and New Zealand. And again, this has been an issue that's been well recognised by the trials group ANZCHOG. And so they've got a specific focus and they've increased their staffing around clinical trials. So they've got trials coordinators, data monitors, trials assistants. Again, they've got a project manager, Dr. Janelle Jones. And again, she's been exceptionally helpful in terms of helping us to write successful grants to the National Health and Medical Research Council to get funding to do trials. Relationships are really important. And again, ANZCHOG has got good relationships, again, with the personalised medicine program, but also internationally. We've got established partnerships already, say the Children's Oncology Group. And again, I was highlighting before that there's a regular discussion between ANZCHOG and Children's Oncology Group, so we can make sure that when trials are being designed, through the Children's Oncology Group, that we can try and promote their access to children in Australia and New Zealand. We know that the Children's Oncology Group are trying to expand their phase of their network of early phase centres, and so we'd like to be able to apply for some of those trials to be coming to Australia and New Zealand. We've got good relationships with CEPN. We've also got an associate membership status with the Innovative Therapies for Children with Cancer group in Europe as well. We also have regular discussions with pharma partners, and that happens not only at the ANZCHOG level, but also with individual centres. And again, I've tried to emphasise in my previous talk, it's really important to support sort of the links with basic and translational research. There are lots of problems and nothing is a solved issue, but post-trial drug access, compassionate access, registration and funding of new agents is also really, really important areas that I really haven't touched on. Many clinical trials with new agents will often have a mechanism for ongoing drug supply after a study is closed. And that's really important. And that's something that's actually very closely scrutinised by human research ethics committees, because they're often unwilling to allow trials to open if they only provide time-limited supply of drugs if they're providing benefit. Many drug companies are very good. They've got compassionate access programs. And so sometimes if you can't access a clinical trial, you can sometimes access new therapies through a compassionate access program. And this is where data can be really helpful. And particularly data, say, generated through a personalised medicine program can sometimes also be very helpful to give it to a drug company. Say, look, we've got a child, we think this drug will help, here's the data, and that can then help you access it. The other thing that's also important after trials, if trials are successful, then drugs are not regarded as being a trial agent. They're becoming part of the standard of care. And so again, this is another complex area, because once a drug is regarded as standard of care, often it's not used as a trial drug, and then there needs to be a mechanism to be able to get guaranteed supply in each country. And that's a very, very complex area. And again, it's something that's been recognised by the Australian government. And so there's been a new mechanism to fund very high cost therapies. And over the last year, there's been a fair bit of work to sort of fund some of these new high-cost therapies. There's been success, particularly with CAR T cells for leukemia. And again, we've been going through the process of working with that regulatory process with one of the drug companies to get one of the anti-GD2 antibody therapies registered and funded in Australia. So that's where I wanted to leave it. And then I hope that we've got enough time for lots of questions.
Thank you so much, Dr. Traher. Thoroughly enjoyed that presentation. We do have 2 questions. I might read them out for you, Dr. Traher, so you can just respond. The first question, which has 3 likes, is from Spiros, who says, you talked about the process of bringing clinical trials from Europe to Australia through the CEPN collaboration. How about the opposite direction? So can European countries benefit from ongoing investigations and trials taking place in Australia?
Yes. Sorry.
Yeah, and then Spiros says, we're all intrigued by Professor Haber's presentation and early preclinical results. So over to you.
Yeah, look, really nice question. And so this is, again, one of the things that's really important. You get exciting results in the preclinical and translational space in the laboratory, and you want to take that into clinical trials. Can data that's been generated locally in Australia benefit other children? Yes, it can. So in terms of DFMO, there's been a lot of interest in DFMO, and a lot of actually lab groups around the world have worked on that, including the groups at Children's Cancer Institute. And so again, with their collaborators overseas in the US, they've been instrumental actually in doing a lot of the biology around DFMO. So that's work that's been done by Michelle's group, David Ziegler. And again, that had led to a trial which was run through NANT, which is the New Agents for Neuroblastoma Consortium. And again, that DFMO high dose trial has then gone into the Children's Oncology Group. And so from that perspective, yes, there is certainly scope for that. With the ITCC, so that's the Innovative Therapies for Childhood Cancer, again, they have regular meetings. ANZCHOG has an associate membership with that. And so again, it can be a 2-way process where you can put together if you like, an application to say, we've got a good idea, we've got great data, we'd like to run a trial. And so then that can go through the processes of designing a trial and getting it up and running. So it could be made available across the world. So can research that's being done here in Australia be exported and used by other groups? Certainly.
Great, thank you. And a final question, unless other people want to submit further ones, there is still time, from Vicky, who asks, with so many trials being early phase 1 or 2 trials, which as parents may not offer the curative approach we need, how can the trial groups accelerate early phase trials to late phase trials?
Yeah, that's a good question. And again, classically, early phase trials are done in a population of children, usually with relapsed or refractory high-risk neuroblastoma. Unfortunately, cure rates in this group are not high. And again, as I was sort of indicating, a lot of the goals of an early phase trial are really allowing us to generate information to know, can we use a new agent successfully? Is it safe? Does it cause toxicity? There's a lot of interest and research that's going on to see if we can actually then convert responses in patients with relapsed refractory disease into cure. And there's been quite an active discussion through the CEPN group about how do we go from patients who've got refractory relapse disease who respond to treatment, how do we turn that into a cure? Again, I don't think that there's a clear, definite pathway yet, but there's certainly plans in place. I think the other important thing is that early phase trials are important to identify new agents. Exciting new agents go up into phase 3 trials for newly diagnosed patients. I think one of the really important goals is to try and stop children from having relapses or refractory disease. So again, one of the exciting things to sort of see is how ALK inhibitors and also anti-GD2 immunotherapy and also MIBG therapy are currently being used in the US and Europe in frontline trials. So the idea behind that is you've actually identified an agent in a relapse setting, you show that it's got some activity, you take it into a frontline trial, and what we're hoping is that that will actually improve the response rate so that for patients that the risk of relapse will continue to go down with time. And again, that's probably going to be a major mechanism for us to be able to actually take early phase agents and improve their use, rather than necessarily curing all patients with relapse refractory disease, but also reducing the number of newly diagnosed patients and reducing their chance of relapse.
Thank you. Just a few more questions. Anonymous, how do you decide whether to give COG or CEPN frontline treatment?
Yeah, look, that's a good question. And historically in Australia, we've had strong links with both Europe and North America. And from that perspective, some of the children's cancer centres, they will have a strong relationship and have been using the COG therapy for a long period of time. And that will be something they're comfortable with, and that will be their go-to. Generally, we like to have trials open for children with cancer, and so we will prioritise having trials available and open. At the moment, there are no COG trials open in Australia or New Zealand. We're likely to be able to have one of the CEPN frontline trials open soon. And so from that perspective, in our centre, then we would prioritise putting a patient on a trial if they're eligible for it and the family agree it's a good thing to do. If they do not want to do that, or we don't have the trial available, then we'd often what we regarded as our standard of care. Currently in our hospital, we use the CEPN approach. Many hospitals in Australia use the COG approach. They both work. They're a bit different, as I was trying to indicate. The fact that they're different is not a problem. It just reflects where the research is. They both result in cure rates. However, it's clear whichever approach you need or you use, we still need to do better. And that's why the trials research is really important and ongoing.
Okay, 3 further questions. Can you speak to EFS versus OS when it comes to clinical trials? Memorial Sloan Kettering uses OS data as justification for skipping transplant. I'm curious what ANZCHOG's position is on this.
Yeah, that's a great question. So technically, event-free survival is a survival measure, which is really asking a question, has your child had an event which is classically defined as relapse, progressive disease, refractory disease, or a very severe or life-threatening consequence of treatment? And so it's really a measure of treatment failure, because again, in children with high-risk neuroblastoma, most of the time, you're looking at relapse or refractory disease or progressive disease. Overall survival is a different type of measure, and what it measures is really, are you alive or have you died? It doesn't ask why you died, it just tells you, are you alive or have you died? When we look at survival curves, often there's a difference between the event-free survival curve and the overall survival curve. So the event-free survival curve is often a little bit lower and the overall survival curve is a bit higher. And that difference, or that gap, gives you an idea about the retreatability, curability if you have an event. And so that difference in event-free versus overall survival is important because it tells us about, what's the chance of being able to retreat. Sloan Kettering, again, they tend not to use consolidation with high-dose therapy. Again, they've got a very successful trials and research and treatment program. And again, there are also successful trials and treatment programs using transplantation, which have been developed by the Children's Oncology Group, developed by CERB and the GPOH. Again, it's one of those things that probably Sloan Kettering as a single centre, they've got great results, and in their hands, that's great. I think most other centres, we would be uncomfortable not transplanting at this stage. And again, the recent Children's Oncology Group trial has actually shown 2 transplants leads to a better event-free survival than a single transplant. And so treatment intensification is still happening for children with high-risk disease. It's not a solved problem. At the moment in the CEPN group, they are going to do a randomisation for single versus tandem transplant. And again, if they show also that tandem transplantation, again, results in improved event-free survival, then that will be the standard of care in Europe as well. Again, I'm not gainsaying any of the results that Sloan Kettering have got. They've got just a different way of doing things. And again, sometimes there are going to be differences. And in some regards, that tension between results is important because it drives thinking about the disease. It drives thinking about the treatment and makes people ask questions, well, how do we do it better? Should we be adopting something from that group or another group? So I think it helps stimulate the research.
Okay. Do you have any perspective on the current DFMO trial? We understand that this has been a bit controversial.
Okay, DFMO is used in a couple of different settings, and there's a high-dose DFM relapse trial that's been run initially by NANT in combination with chemotherapy. That's been taken up by the Children's Oncology Group using high-dose DFMO on the backbone of irinotecan temozolomide and also with the antibody treatment in a randomised fashion. There's also been lower dose DFMO used by the BEAT consortium, which is a North American consortium. And as I understand it, they have used low-dose DFMO as an agent at the end of treatment to try and prevent recurrence. They've published some single-arm data. So again, it's a trial that's generated a lot of interest and controversy and discussion. One of the issues around treatment strategies is that there are lots of ways to generate data and information. Randomization in clinical trials does become important because randomization allows you to sort of try and ask the question, does treatment A result in a different result to treatment B? And so from that point of view, the data that has been published so far by the BEAT consortium is a single arm study. And again, it's hard to know exactly because a lot of the comparison is with historical controls. Now, other trials have done that in the past. And at the moment, from my perspective, thinking about as a clinician and as a trialist, the type of data that I'd love to see now is randomized data to sort of see, does it work in a randomized setting? And if it does, that's fantastic, because that would then be adopted as the standard of care. Personally, I haven't had any of my patients on DFMO as low dose. It's not easy to access in Australia and New Zealand. And so I think that's also one of the issues. It has been not the easiest drug to access. At the moment in Australia and New Zealand, the easiest way to access it is really going to be in the relapse setting through the Children's Oncology Group randomised trial, where it will be randomised DFMO plus irinotecan temozolomide antibody versus antibody irinotecan temozolomide.
Maybe just one more question, and for the others that we don't get to, I think we can answer them by email. Do researchers stand out as particularly talented, or is it a team? Who is talented with approaching research innovatively?
Look, I think that's a great question, and I think you need both. I don't think there's one which is better than the other. You need people who have great ideas and are able to make that sort of sudden leap. But you also need collaboration as well. And again, I think one of the really important things in research is you actually need access to lots of resources. And so this is where the data repositories, animal models, access to clinical data is also really important. So you might have a great idea and you've got that leap, but then having access to models and data allows you to then actually look in the data and see, okay, does my idea, does it seem to pan out? Is it likely to work? And so this is why I think it's important to have both. And again, I think it's also important to have a strong collaborative network. So you encourage people to say, gee, that's a great group to be working with. I'm inspired by them. I want to work with them. That's the disease that I want to work in. And again, I think that's really important. I think what's really important also is to make sure that we've got a strong group of young people coming in, basic research, translational research, and also as clinicians who are passionate and have got a drive to work in the area. And so I think, to my mind, I wouldn't say you need one, you need both. You need innovation, you need bright sparks, you need passionate people, but you also need good collaboration.
Thank you so much for your time, Dr. Traher. And I'm sorry, but we couldn't get through all the questions. But like I said, you could shoot them through an email. The next session is coping as a family and accessing support services. So please head back to the Watch Live page and start viewing there. Thank you, Dr. Traher, and everybody for listening.
Thank you very much.